Let me move us to our next speaker, and we will have time at the end of the session for some questions and answers. So please, all the participants, be thinking of your questions and answers, and you can go ahead now and start putting them in the chat box, and we'll collect them and try to deal with them. Let me introduce our next speaker today. His name is CHRONIS Manolis. CHRONIS is going to speak to us about mobilizing the R&D innovation engine. And of course, after the last talk, I think we're all ready to hear now exactly what we need to do to mobilize action here. CHRONIS is the Senior Vice President of Pharmacy at the University of Pittsburgh Medical Center. And he oversees the pharmacy programs for the health plans, Medicare, medical assistance, and commercial products. He has over 30 years of experience in pharmacy and managed care industry. He's previously held positions, management positions at Medco Health Solutions and Statlanders, Specialty Pharmacy Services. CHRONIS is also an adjunct instructor at the University of Pittsburgh School of Pharmacy. And CHRONIS, I'd like to welcome you to our session this morning. We look forward to hearing your talk.
Well, thanks, Carl. Appreciate being here and providing a payer perspective. And thanks to Kristen as well. Very powerful. Always need to be reminded that the patient's at the center of everything we do. So next slide. So I think everyone would agree in our industry that this brand of pharmacy today is about as complicated as it's ever been. You take any one of these, whether it's the transformative drug science, the value evolution, any one alone can be pretty daunting, but all at once, it really creates one of the more challenging environments I've seen in my 30 years in this business. And if you'll notice, there's no mention of COVID on this slide. And so what we experienced and what we continue to experience really is just taking it to a whole different level. Next slide. So, COVID really has impacted traditional disease, chronic disease disproportionately. Conditions like diabetes, cardiovascular, hypertension, obesity, this is all kind of what Carl reminded us of, is really it just took lives way earlier than it would have otherwise. Next slide. And so, what we've got in our industry today, the R&D focus has all been on the transformative drug side, the rare and chronic disease side, as opposed to chronic disease. And so today in pharmacy, we're seeing that half of all of our drug costs are on specialty drug, yet it only impacts roughly 2% of the population. Next slide. And this is reflected in our pipeline, again, showing the disproportionate attention that rare disease gets, things like cancer, neurologic disorders, et cetera. And really, traditional chronic disease is really underrepresented here. And I think Carl reminded us of that in his own company. To get a little closer to the ground, for years, we've had mainly generic classes in things like hypertension, mental health, antihistamines, non-stating antihistamines, statins, peptic ulcer disease. No real innovation in those areas. And if you think about it, those are the areas that have been kind of hit hard and exposed by COVID. And it really just exposes, again, going back to Kristen's presentation, the real impact and human suffering that we're seeing right now. Next slide. And so, I'm certain that managed care payers are somewhat to blame given for this shift, because access, the business model, formulary changes, that all really impacts whether a manufacturer is going to create a program that goes after these types of disease. But I can tell you that we've had a lot of recent success in drug innovation in chronic disease. You look at diabetes, you look at the SGLT2s, the GLP-1s, they're a pipeline in a product. They're cardioprotective. There's the heart failure data that's coming, the kidney disease data, anticoagulation, the DOACs. Probably go back 5 or 6 years, warfarin was still a big player in our plan, in our Medicare business, over 97% of the people are now on one of these DOACs. It literally has wiped warfarin off the face of the earth. And in migraine, for years, we've had the triptans. They were mostly all generic. I would say the outcomes were probably modest. We lived with it. And in the same year, we get multiple products for chronic migraine use, multiple products for acute use. And I think these are really important products. And, I think managed care access has been there, and it's been a success story. So I believe we've proven that innovation, there'll be room for innovation even in the chronic space. Even the PCSK9s which were really one of the poster childs on first agent we've had in for cholesterol in a number of years. They just weren't priced right. And I think the industry felt like, with statins, we're not sure about the PCSK9s. But if you fast forward a couple of years, I think you'll find PCSK9s are out there. They're a valuable weapon for that slice of patient, and managed care has accepted them. Next slide. So there's no question that payers will get behind innovation. And moreover, our members, our providers deserve access to these truly differentiating therapies. So if you think about formulary status, which is kind of always the point, why invest all this in a drug if you can't get it on formulary and if no one will have access to it? I can tell you that as someone who leads a $4 billion pharmacy operation, mechanism of action, clinical materiality, and differentiation, they always have a place, right? They'll always get a look, and it's all about the data. Today, it's about total cost of care. That's the ultimate goal. We as a payer feel it's more important for our members to be educated about these new diabetes drugs, educated about why it's so important to take your DOAC, even when you don't feel a little different, or maybe when there's an affordability challenge. So we will actually assist and push forward the goals because we know these drugs work. And one of the areas we spend a lot of time on is that when you have differentiated therapies in diabetes, et cetera, we're proving that you see downstream offset in medical use. And that's what really matters. There's benefit design. We were probably, I'm still looking for another plan in the country that did this, but in our Medicare book, which we have 200,000 Medicare Advantage lives, we moved all of the diabetes drugs to the generic tier. So if you think about access, and if you think about typically type 2 diabetes, there's multiple comorbidities, and patients have trouble affording their drugs. We looked at it and we said, look, the data and the evidence on these agents are really compelling. And how do we take cost off the table for these members and make sure they take the drugs and educate them about it? And it's been a real success story so far. And it's been an actuarial challenge, right? There's a lot of folks that said, why would you want to attract diabetics? And we say, look, we feel like the agents that are in place today, if people can have access to them and they're knowledgeable about why and when and how they should take them, that we'll see a total cost of care reduction. And you look at our Medicare benefit design, there's more zero copay tiers than ever. It's drug promoting benefit design rather than the other way around. And I think we just all need a value-based construct. We need the price for value. We need a change in thinking from traditional business algorithms, and kind of let's meet together. I love that slide that Kristen put up there that we all need to work together. It's exactly what we need to do here. Next slide. So, I'm sorry, I don't see my slide. Okay, got it. So how do we mobilize the R&D engine for traditional disease? And I think we're all here incented to fix the unaligned incentives against innovative new brand therapies. why we still have a donut hole, why that was all created is so deep political. But at the end of the day, how many years? We're 14 years beyond Medicare Advantage, and we still see that when patients hit the donut hole, they pull back on therapy. They've got to make decisions based on food, drug, other issues, heat, etc., gas. How do we fix that and make sure that patients have access uninterrupted? We were a plan that did the Insulin Saver program last year that provides cost certainty for all insulins, regardless of whether you hit the donut hole or not. And what we're seeing is that people are adherent. They're staying on therapy. How do we fix the PBM rebate machine? We cannot continue to have a toll-taking model that makes the business model, it kills the business model before you even get there. How do we leverage increasing demand? We've got more physicians in risk environments in an ACO setting than ever before. They want access to these differentiated therapies. And so we're incented, payers and providers alike that are in these arrangements, to make sure people have access to the most differentiating drugs, because it's total cost of care that matters. And then an educated and engaged consumer. We spend a lot of time as I've got a pharmacy care management staff that spends a lot of time engaging our members, talking about the importance of adherence, the importance of understanding your condition, what the drug does, et cetera. And so, my final observation here, what does an optimal pharma business model look like? How do we, the masses, right? I'll end the way I started. 1% to 2% of our patients are driving 50% of our costs, but those other 98% really are driving lots of emotion, lots of cost, and just poor outcomes. So how do we fix the waste drivers? How do we get around things that, again, that we could spend all day talking about how we got here, but whether it's patent extension tactics or just endless inflation, that, just because you can, how do we align the incentives and really start to look at that? So again, I thank you for allowing me to provide this perspective, and I'll look forward to our Q&A in the panel discussion. So thank you.
Great, thank you, CHRONIS. You kind of built on the platform here, and